Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. My guest today is Malekeh Amini. She's the CEO of Trayt, and I'll spell Trayt, T-R-A-Y-T, Trayt. Trayt offers a disruptive data analytics and clinical intelligence platform that supports mental and behavioral health access while providing a collaborative approach and maintain a 360-degree personalized view of the patient. Malekeh, thanks for joining the Tate Chronicles.
Thank you for having me, Jim.
I first met you and had a great conversation at the most recent HIMSS conference. Certainly learned quite a bit in that discussion about really social determinants of health, how it regards behavioral health, and I'm looking forward to continuing that conversation today. But let me first inform our listeners that Trayt will be at the Health Conference, of course that's spelled HLTH, Health Conference in Las Vegas, that really just is almost on top of us. It's October 8th through 11th, and Trayt is going to be at booth 6437. That's 6437. So tell us about Trayt Health, the company you founded. Why did you find Trayt Health?
So you did a great job of describing what Trayt Health is, but Trayt is a clinical workflow data collection and data analytics platform designed for behavioral health. Our platform is focused on the kind of the interplay across the brain, the body, and other environmental factors, including social determinants of health and like childhood trauma, for example. Trayt's created a platform that maps more than 750 symptoms and factors that impact behavioral health symptoms. And we enable clinicians to make more informed assessment and treatment decisions about patient health, in that behavioral health space. Sorry, go ahead.
It just struck me, that number, 750 different factors. That's a big number. So what are these kind of numbers? These factors. Give me some examples. Are those about gender, ancestry, ethnicity, food shortage, seat belts, guns in the household? What are all these 750 different factors?
So 750 different factors include multiple different things. One is obviously at symptom level, all of the behavioral health symptoms. So what does the patient's mental health look like? The other factors are other medical symptoms. So, does the patient have any other medical conditions, and what do they look like? And then there are, that we talk about social determinants of health, and the definition has been kind of big, broad categories. And in our view, it needs to be broken down into smaller bits. So social determinants of health have been traditionally food and transportation and housing and kind of the general socioeconomic factors. We actually break that down into a number of different areas of, home environment, childhood trauma, adverse childhood experiences, and other things, like a more granular level of environmental factors around a patient's home environment or, just life environment. And it does break it down into the granular levels that gives us a much better picture of those non-medical factors that could cause the medical symptoms that are we're observing. So the 750 include both those medical factors across your brain and body, and also the non-medical factors that drive those other health issues. So that kind of creates the 750 data symptoms and factors that we measure on a regular basis. And our view has always been that social determinants at that granular level and the expansion of its definition into the full environment of a patient needs to be included in the day-to-day clinical care of the patient if we want to be able to really assess how a patient is going to make progress on treatment.
I imagine one of the reasons that you founded Trayt is that the behavioral health care domain is so fragmented right now. So let me see if I understand what Trayt does. So at one level, Trayt is a documentation tool that is used to document and gather information about a particular individual.
Mm-hmm.
At another level, it's a collaborative tool. So healthcare team members are kind of kept up to date on the patient process. So are those the two main things that Trayt Health is doing?
So we do, I mean, that's definitely one. We collect data and we analyze the data from the thing that makes us unique is that we collect the data from the entire ecosystem around the patient. So we collect data from patients, we have family-facing applications, school-facing applications, primary care-facing applications. So everyone is contributing data at that same granular 750 factor level, observation data into the application. We also streamline clinical workflows for not just an individual clinic, but we particularly have the capability and have scaled and have the functionalities to enable what is called the statewide psychiatry access programs, which are collaborative programs. So they enable, primary care physicians and the schools to deliver care for patients exactly where they are in order to address, the issues of, access to those types of services. So what we do is we create those networks. We connect all of these entities that traditionally don't work together and are not at all connected to each other, and enable the access programs to function with a streamlined workflow. And because of the fact that we include social determinants as part of the integrated kind of data into the platform, we actually enable the programs to also measure whether they are providing more equitable care, equitable access to care, not just whether the patient's getting better, but are we seeing patients where they would otherwise not have access? And that's what the Trayt application is uniquely, is the first technology that has been able to enable the statewide psychiatry access programs to provide that type of care and to measure their impact on health outcomes and on better access to care.
One thing that I'm always interested in healthcare is the gathering of data. And then, all the time we're always hearing about interoperability. Nobody's quite sure what it is, but when we recognize it, we certainly appreciate it. Is your application now? I know it's probably patient facing, care team member facing. It's that 360-degree ability to input data. Is the data all input or documented in a manual fashion, or can electronic files be imported, or how's that looking?
Yeah, no, it can be imported and it can also export into electronic medical records. So we definitely have direct data entry ports for manual data entry. And those are necessary because Trayt is a pure outcomes and health data platform. So that data is not collected in the electronic medical record traditionally, right? So we collect granular levels of data that is inputted by other people, not just a clinician. The current electronic medical records, and I wish we could change that conversation forever in the US, but the main platform used in clinical settings is the electronic medical record or the electronic health records. And those are primarily, they started off and they remain an administrative streamlining tool and were revenue management tools. So they really streamline the claims process and, e-prescriptions, and making sure that, the administrative workflows are all streamlined. But they never were built to and they're compliance tool, right? So, for any audit that needs to happen, the electronic medical record needs to show that the proper documentation was done, the proper assessments were done. So there is a very different purpose for those. And we actually are pure health outcomes, pure health data, and really giving the clinician what they need to make a decision at that clinician visit with the patient, instead of doing, kind of documentation for the purposes of filing a claim. So what we do is we integrate with electronic medical records, and that's basically interoperability at its most basic level, is to make sure that you integrate with the electronic medical record to receive from the electronic medical record the data that you need in your application. So we pull in, for example, some of the diagnosis or symptom level data or medication level data, because they use coding libraries in the electronic medical record that we don't use. So we import that information into our application. But then we have streamlined and automated all of these validated, standardized measures that need to be part of the clinical setting. And those are typically on pen and paper. We have streamlined all of that, but they are needed for compliance and for reimbursement for clinics. So what we do is then we push that information as a document for those purposes into the electronic medical record. So that's the basic interoperability. But where we don't have traditionally interoperability is across institutions. So if you're sitting at Baylor, regardless of how many times I've integrated with the Baylor electronic medical record, for the statewide programs where Baylor and Texas Tech have to work together, those electronic medical records are not connected to each other. So we as Trayt will integrate with every one of those electronic medical records, but we sit on top of those. So for psychiatry access programs, all clinicians can have data accessed for those patients that are treated in those programs. So we raise that level to connecting all of the institutions, the medical institutions that typically do not work together, and there is no interoperability plan around them. That we enable that. We connect them as a single network of providers, and they can see patients. So a patient could be sitting at a school close to Texas Tech University, but Texas Tech doesn't have a psychiatrist on staff today, and someone at Baylor in Houston can see that patient. And it's a different institution. It's a completely different geographic area within the state, and we enable that. And that's a very different level of interoperability.
I want to talk about some scenarios in just a minute, but first, to our audience, if you're just joining us, I'm Jim Tate, and on this episode of Tate Chronicles, I'm speaking with Malekeh Amini, who is the CEO of Trayt. With all the data that is being gathered, is there a predictive component here? Go ahead. Sorry. Yeah.
Not today. The predictive component comes with more longitudinal data. If you want to really use it as a predictive model, and we are building that data set, and our longitudinal data is very quickly building up because we go through a single statewide deployment, so we scale very quickly with patients. But there is sufficient research that has been done that could provide more predictive models around how do you assess what is the primary symptom that's driving everything else in a patient's health, because they're all interconnected. I use an example for you. If you see two patients with autism, right? Both of them are autistic, both of them are nonverbal. They could even be in the same family, right? So a lot of demographics are the same. But one patient is much more aggressive, for example, than the other patient is, right? Aggression is a traditional symptom of autism. Self-harm is one, and the nonverbal is another one. So these are all, they're all autism, but the patients look very different from each other, right? One is very quiet and in a corner and not, doing anything. The other one's really aggressive and screaming all the time, right? So the way we function is we actually we collect so much data that, let's say for the patient that shows a lot of aggression, that patient also has some gastrointestinal or digestive issues.
Mm-hmm.
And so one of the things, and we have actually had this as an experiment with 2 patients to compare. So if you send that patient as an example, if that patient actually got treated for the gastrointestinal problems, and then all of the other symptoms of autism, the severe aggression, the screaming, all of those things went away. And that patient became a different type of autistic kid. It was much more quiet, much less harmful to himself and to family, right? So it's really understanding what primary symptom should be treated that could help bring everything else to a better place. And then you avoid a lot of throwing medications or over-medicating a kid, right? Or any individual. So those are the types of things that we highlight. And those could be today, you don't even need to predict them. You can just create a level of severity or show what appears to be the primary symptom with some level of confidence. And a clinician still remains the gold standard. They still need to make that decision. So we're not telling them go here, but we're telling them this is what we have collected and analyzed. And our assessment is the GI is the primary symptom. If you address the gastrointestinal, you can improve everything else before you medicate them any further. And then patients potentially could just stay on basic levels of therapy and not need any medications if you just treat the primary symptom, right? And so those are the types of examples of, if you talk about prediction, no one will predict any of it, but you can provide a much more directional, more accurate, more granular level of information where a clinician is able to predict.
Exactly.
This is probably the one, right? Yep. So that's what we enable.
I understand totally. And, that the idea of a predictive model, just on its face sounds fantastic. And that has hyped AI to artificial intelligence or augmented intelligence to quite a bit. But if those systems have not been trained on very large databases, that involve different ethnic groups, different cultural groups, all kind of different things.
Age, gender, demographics.
Exactly.
Everything is a factor. Right?
Exactly. You're going to have implicit bias in the code, in the code.
Definitely.
Absolutely.
And we rely on that. We rely on predictive models. We rely on machine learning. As we keep growing, our data sets gets, more and more, our algorithms get more refined. Our data gets more it's a lot easier to train a model when you have a lot more data on a much more diverse population of patients. So that's definitely, we rely on that. But at the end of the day, it's not even, I think AI is a huge factor, and there's a danger to not using it properly. Our goal is to always remain evidence-based, and that the AI models train according to those principles still, to give the clinician the best data that they need to make a good decision. At the end of the day, AI, machine learning, any of these health platforms are not going to replace a clinician's judgment and a clinician's decision and a clinician's direction. And that's the mistake that I think a lot of, the industry, not this industry, but in general, we talk about generative AI or chat GPT as a replacement for making things happen, or driving all of our decisions. And I think in healthcare and in several other industries, honestly, it is very dangerous to go down that path. I think it's important to train evidence-based data. It's important to train models over a period of time. And it's also really important to train them for the purposes of a clinician using them, not for providing direction to the patient or providing a definitive answer. Right? And our goal is to always be a tool for clinicians to make better decisions.
And so Trayt, I guess at its highest and best use, is a network. And folks have to be connected to that network to really get full advantage. So let me ask you about a scenario. So let's say a primary care provider believes that a patient needs behavioral health support, diagnosis, or whatever. If they're part of your network, what would be how would they do referrals? How would information? How would it actually work?
Sure. So, a patient sees, let's say, I'm going to use an example of actually something that shows the extent of the network. So let's say a patient is 16 years old and goes to their pediatrician, which is typically, it's a female 16-year-old goes to pediatrician, and this patient is pregnant, 16-year-old pregnancy. So, and the patient is showing signs of, this is obviously could potentially be an anxiety, kind of state of anxiety for a 16-year-old. So the primary care is observing those symptoms. And let's say this patient has also had prior history of ADHD and is taking Adderall, right? So that primary care physician is really not equipped always to make a decision about should Adderall continue or not. The patient is showing signs of real anxiety and meltdowns, and it's causing them to start to fail at school or have other, other issues, other life issues as a result. So what do I need to do? They're not always equipped to make those decisions right at that office. So our application for those that are connected to the network, so primary care has to enroll in the program, but then I'm going to assume that primary care is connected to the program. But what they would do, or they can sign up online, but what they would do is they would they log in and electronically submit a request for a consultation. And that consultation goes to our clinics that are providing behavioral health interventions and support. So they're, therapists and psychiatrists sitting on the other side of the application. So it sends a consultation request. a psychiatrist from, let's say, Baylor calls the primary care physician back within 30 minutes. So that's a key piece of information because you have to wait 6 months to get into a psychiatry clinic.
Sure.
So they get a call back within 30 minutes that says, okay, I saw the basic information you submitted. Let me ask you a few more questions. And they go through a full conversation about the condition of the patient that gets documented. The behavioral health specialist or the psychiatrist is documenting all of that structured data. What is the patient taking as medication? All of that information gets documented on Trayt, which is why it helps train models. And so it gets added. And the psychiatrist then says, okay, based on the information you're giving me, they could even assign a standard like a PHQ-9 or a SCARED or GAD-7 to say, hey, have your patient complete this. And I want to look at the results before I make a recommendation. So that loop also happens on the Trayt application. And then the psychiatrist would say, here are my recommendations. Why don't you let the patient stay on Adderall, provide a small dose of, Zoloft to reduce the anxiety level. But the difference is that when this consult comes in, depending on the profile of the patient. So this patient is a pregnant teenager. So the first thing that this does is that it gets transferred to a perinatal, to a reproductive psychiatrist, not a typical child psychiatrist. So we connect it to a reproductive psychiatrist that can make medication recommendations for that patient, because at the end of the day, that patient is a pregnant female, is not a teenager anymore, right? And so that's the first place that it goes. And then that call gets transferred seamlessly. Primary care never knows about all of this. This is just in our back end. Then it gets transferred to a child psychiatrist, an adolescent therapist, to provide some tools for coping, to provide some other types of resources for the patient. It still goes to the primary care, but they do provide resources and other types of advice that are relevant to a teenage patient. This is no longer about the pregnancy. The pregnancy is medication, reproductive psychiatrist. Still, the 16-year-old adolescent needs an adolescent therapist. So it gets seamlessly transferred between child and adolescent to reproductive, back to child and adolescent. But the primary care, the only thing that individual knows is I have a problem, I submit a request for a consult, and I get a call back, and it solves all of my problems without my knowing how all happened in the background.
Wow.
We just got the recommendation, and then they deliver the recommendation to the patient, and the patient leaves without needing to see a psychiatrist because they were treated at the clinic.
That is, so it's not just a referral type situation. It's a collaborative, consultative type
Exactly. This is the
environment.
consultation. Exactly. So
Exactly.
that same primary care physician might have a patient that has some severe signs of anxiety,
Mm-hmm.
in which case this program may not be the most appropriate program. That patient might actually need direct intervention. So at that point, they would submit a request. They would submit actually a referral, direct referral online on our platform. They submit a referral, and our school-based program has got national attention for this. So, if that kid is sitting at school, but the primary care can do the same, they would submit a referral of a patient. The psychiatrist will call back, someone will call back, make sure everything has been clean, data is all there. And what they do afterwards is they have roughly 5, but there are, various, programs, 5 to 10 direct interventions on telemedicine. So again, the patient never needs to go in. It's a telemedicine set of interventions and interactions with the patient directly until the patient has been stabilized and is no longer in a more severe situation. And then they provide referrals to long-term care. So a community health center or some other local therapist can then see that patient on an ongoing basis, but they avoid the escalation of a patient's situation as they wait for a 6-month appointment.
Exactly.
Right? This solves that problem.
And we're almost totally out of time, but I'll tell you one thing I like about your approach and your solution is it reduces the friction.
Absolutely.
And anything that can be done to reduce friction is great. I want to say to our listeners, if you want to find out more about the work that Trayt's doing and their applications, that's at Trayt.health, Trayt.health. And if anybody's going to be at the health conference this week, October 8th through 11th, just starting in a few days, you can stop by and meet Malekeh at booth 6437. And I believe you've got a big presentation coming up Tuesday afternoon on the Impact stage.
We do. Actually, this goes back to one of the things that you asked about, how do they get connected? So we're going to be talking about the impact of social determinants at an expanded level on patient health. So how do you think bigger about social determinants? So we're going to be talking about how a patient's environment can impact their ongoing health on a daily basis. I'm going to share the stage with Dr. Roshni Kohli, who is the medical director at the Meadows Institute for Mental Health Policy, and it's going to be moderated by Marnie Hayutin, who is the content writer for Ritz Communications, but also has had an incredible research and content around social determinants of health in her past. So very much looking forward to it.
Well, we're totally out of time. I've got to say to our audience, thanks for joining me on this episode of the Tate Chronicles. And I offer a special salute to my guest today, Malekeh Amini, CEO of Trayt. Malekeh, thanks for joining today.
Thank you so much, Jim. It was great to talk to you.
Yeah, it's great to catch up. You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.